Hey y'all, welcome to the Team LoCoFit Roundtable, hosted by me, Laurin Conlon, owner of Team LoCoFit. Each week, I am joined by one of our coaches to dive headfirst into the nutrition, training, mindset, and coaching strategies we use with our clients. If you loved the show, please subscribe, leave us a review, tell a friend, you know the drill. And for more information about coaching, the programs we offer, and additional content, visit teamlocofit.com.
All right, y'all. Today I'm joined by a special guest, Victoria Felkar. I'm so excited. If you guys haven't listened to the other two podcasts that we did, they were on birth control and hormones and all things female related. So Victoria is back, and we're going to do a two-part series on PCOS, which is so misunderstood. There are so many questions surrounding this diagnosis, what it is, what it isn't, and also just how to actually, live your life with this and how to actually manage it. So first, before we get into it, Victoria, thank you so much. Give a little background for anybody who didn't listen to the other podcast. Like, who are you? Why should we listen to you?
I am a interdisciplinary researcher from the University of British Columbia. I'm finishing my doctorate right now in women's health, but specifically female athlete health in terms of menstruation and reproduction, looking at different types of hormonal states, such as one of the ones we will talk about today, hyperandrogenism, and also the use of oral contraceptive agents and, hormonal contraceptive agents, but most commonly oral contraceptives and other steroids, even such as anabolic androgenic steroids. So that's me. And I also, PCOS is very personal, as I was diagnosed with it when I was 18, 19 years old. And we'll get into some of that because I definitely think that there's a lot. There's just such a loaded topic. Yeah, it hurts my brain, and I'm researching it.
Yeah, so. It's one of those ones that really got thrown into the bucket of like being misunderstood. And I feel like because it's so misunderstood, it's so widely used, right? Like people will just be like, oh, you must have PCOS, right? It's just the same way that a lot of people have IBS. Like that'll just be a diagnosis. And you're like, well, there's a lot more to that, right? Than just saying. Or
metabolic damage.
Oh, yeah. That's right? A good one. Yeah. Thankfully, we haven't heard that as much anymore, but it's still in the industry, right? Whenever you hear like a big, scary word, those are the ones that stick around.
Even adrenal fatigue.
Adrenal fatigue is another great one.
Yeah. And that's, I think.
Leaky gut. So all of these things are actually real diagnoses. Well, adrenal fatigue is kind of still on the periphery of is this real or not. We all know when we hear those words, there are symptoms and issues attached to it, but what they actually are and what can actually be done about it is what's so misunderstood and what's so bastardized. So that's why I'm really excited. Like the first thing we'll dive into, okay, what is PCOS? And also like, what isn't PCOS? Like, right? Like where are these diagnoses kind of coming from and how does this present?
So PCOS stands for polycystic ovarian syndrome. So that's kind of the first place, is knowing what the terms are, because believe it or not, I have worked with women over the years as a practitioner, and they were diagnosed with PCOS, and they didn't actually understand what the acronym stood for, which is so sad. But I don't, I'd rather them not Google to find out and come see me instead, because if they Google, you go down that massive abyss of a rabbit hole that is just so confusing. And like, I will, with complete transparency, admit that this is one of the topics I have had my eye on for years. Well over a decade now. And because of my personal story as well to this, but it was something that even in this last, let's just say 10 years, the growth in research has been astronomical. Like even this last month, I think that I found in July has been 16 new like elite publications, like not That's our awesome. Baseline open source, but 16, which is it. Great. However, all of them have different ideas around what it is, what it isn't, how to treat it, how to diagnose it. So there is no consistency with it. And that is something that is really tricky. And it's something that has altered and shifted everything from clinical reports on how many women have it to, even just understanding for like insurance purposes, what drugs can be covered. Because certain drugs, a doctor will list as being PCOS treatment, and the insurance agencies are like, but that's not what we have for our PCOS treatment. So it's this giant mess. And so for me, starting at the very beginning is like the best place to start. So reproductive endocrinology is a relatively new phenomenon. So we're talking about like 1920s, 1930s. So some of us have grandparents that were born in the 1920s and 30s that are still alive today. And reproductive endocrinology was not a thing. Even reproductive sciences was still kind of like this growing discipline. But why I say that is that there was a lot of decisions made in a very short period of time with very limited understanding about even things like the menstrual cycle and what was the events that happened inside the body that created a normal menstrual cycle. And so we started just throwing diagnoses at different things that maybe shouldn't have. Super murky, crazy time. But with that being said, 1935, there was two researchers, Stein and Levantine, who first kind of decided on this very unique gynecological condition. And they described it as women that had a combination of obesity, hirsutism, which is kind of outward signs of high androgens that typically we associate with high androgens. But I have to say it's a little bit more confusing than that. But for our purposes, things like facial hair growth, secondary hair loss, so along the scalp line, acne, as well as amenorrhea and bilateral enlarged ovaries. And so they're like, there's this thing. And then that was that for about a couple decades. And all of a sudden, we fast forward into the 1990s. And the category and kind of clinical guidelines for this thing called polycystic ovarian syndrome got defined. And it got defined with either two processes had to occur: hyperandrogenism and ovarian dysfunction. And the hyperandrogenism, it could be clinical or biochemical. Clinical meaning that there's signs of it. Biochemical meaning that you have lab work and it shows high levels of androgens, even if you don't have any outward clinical appearance of it. Then about just over 10 years later, a new guideline, or actually, like 13 years later, a new guideline came out. And now all of a sudden it was hyperandrogenism, same idea, clinical, biochemical, ovulatory dysfunction, and polycystic ovarian morphology. And the individuals only had to have two of these in order to be diagnosed. So what that meant is that since 1935, people that got diagnosed with this kind of phenomenon had to have things like obesity and amenorrhea and enlarged ovaries and obesity. Then all of a sudden in 2003, they no longer needed those to be diagnosed. So you could now be diagnosed with polycystic ovarian syndrome without having hyperandrogenism, which was a hallmark part of the diagnoses, and now just was gone out of it. So women could now be diagnosed with polycystic ovarian syndrome if they had an ovulatory disturbance or dysfunction and polycystic ovarian morphology, which I have to say, and we're going to get into this a little bit more, that's what happens. Polycystic ovaries are what happen when you don't ovulate regularly. So it's kind of like, duh. 2006, there was pushback from the Endocrine Society. And they said, no, you need to have hyperandrogenism, and you can have either ovulatory disturbances or polycystic morphology, either of those two things. 2009 comes around, they redid them again. 2013, they redid them again. 2016, they redid them again. 2019, they redid them again. And 2019 to 2020, there's now about, honestly, 5 to 7 different clinical guidelines that get used, even with an international, like, polycystic ovarian steering committee. Nobody can decide on what this is. And what makes it even more, I guess, challenging is that we're looking at symptoms. We're not looking at why somebody might have ovulatory disturbances, or why somebody might have clinical or biochemical hyperandrogenism or high androgens. They merely are labeling a piece of a much bigger puzzle. And so that, for me as a researcher, uber problematic, very poor research right there. You don't just label something without fully understanding it. But unfortunately, that is, that's medicine. So the best thing I can use to describe the best term for PCOS in 2020 is that it's a panacea. And so it's literally one disease that's been applied to a whole bunch of different phenomenon, even when it hasn't been associated with those in research, or it's been refuted, or it's been challenged, and that it really is simply a group of symptoms that have all different underlying origins, manifestations, and impacts for individuals.
So clear. That really clears it up. We should just end the podcast. I know you guys totally have all your questions answered. So this is a very frustrating thing to not only diagnose, but as, of course, the person who is being diagnosed, right? Like the patient, who then, I would imagine, and this is just me going on a limb, that there's probably people who don't even do blood work, who just say, yeah, you have this, or they don't even do the ultrasound and they say you have this because it fits a few other boxes. And that's really dangerous, and that's really upsetting to people, right? Because then, if you just say, hey, you have PCOS, you slap this label on, right? And then somebody does go and look up information about it. And we have a whole bunch of questions that we're gonna answer on the second podcast for you guys. And everything from fertility to insulin resistance to this to that, like you must be low carb and you got to do this, and all of these issues now, right? And you start reading these things, and it might not even be the correct diagnoses. And thankfully, there's been more interest in it sounds like recently, but that can also add to more confusion.
Absolutely. And I think one of the difficult things is the name. So you can have polycystic ovaries without having polycystic ovarian syndrome. They do not equate to the same thing.
Yeah,
exactly. Like that is so confusing, because an ovarian cyst, there's many different types of ovarian cysts, first and foremost, and that the ovarian cyst within polycystic ovary syndrome, or just polycystic ovaries, is that you essentially, during a normal menstrual cycle, your ovaries release an egg every month, or they should if it's an ovulatory menstrual cycle. The egg grows inside a follicle. The follicle will either not break open and then it develops into a cyst, what's called a follicular cyst, or it will break open, releases a mature egg, and you can either have a corpus luteum cyst if it kind of doesn't actually go as planned, or the follicle will shrink and form, and then all of a sudden it helps prepare for the next menstrual cycle. Reproductive biology in like 2.2 seconds. But long story short is that follicular cyst or corpus luteum cyst, they're essentially just a fluid-filled sac. And the more that you don't ovulate as a woman, the more that you hold on to these eggs, because we're born with a set number of eggs. So it's kind of like all your eggs are sitting in your ovaries, and some of them have been stimulated by certain hormonal responses, but then they don't go through the full chain of events. And so if you have an ultrasound, it's going to show that you are holding eggs. So this could happen if you're amenorrheic. This could happen if you have some type of structural occurrence, such as issues with the endometrium or your cervix, or even just with the hormonal signals being sent. It could happen completely. Genetically, some women just have issues actually going through the full chain of events. And there's so many different underlying reasons why somebody might have A, an ovarian cyst, B, cystic ovaries, that do not automatically equate to what we describe, think we understand about this syndrome known as PCOS. So I actually don't use that name because, just to add more confusion to it. But because I find that it's really, it's like calling a bird that quacks a duck. right? It's like,
you're
yeah,
close,
sure, you're getting
but-
close, you could, but there could also be other birds that quack that aren't ducks. So it, you don't, and like, then here's the other thing, you don't actually have to have cysts on your ovaries to be diagnosed with polycystic ovarian syndrome. Again, so confusing. So confusing. And
would you say that
hard.
one of the hallmarks would
Yeah.
be the hyperandrogenism? Like that
Correct.
has to be, like that would be one of your hallmarks that you don't deviate from.
If you look at the different, and so phenotypes, there's these different phenotypes, and phenotypes just mean a set of observable, oh my gosh, my speaking today is not good. Observable characteristics, whether
Don't worry,
that's,
that's me every day. So
yeah, whether that's in lab work, whether that is through other types of diagnostic tools such as ultrasound or vaginal ultrasound, whether that's through observable, so just actually looking at you and seeing if you have X, Y, and Z. So the phenotypes, they kind of allow us in medicine to make these unified approaches to actually diagnose and treat. The thing is that those are based off of, especially with PCOS. I feel like it's like Prince and then the artist formerly known as Prince. That's kind of what we need to do with this, is like just the syndrome commonly or formerly known as PCOS that Victoria calls something totally different. And we'll just go like that for the rest of our interview because it's so confusing. But that they allow us to create like these easy ways to diagnose and treat people. But then with this particular instance, they make it so hazardous because women get treated for high androgens when they don't actually have high androgens, or women get treated for anovulatory periods when they might have high androgens, but they have ovulatory periods. Like it's so messy. So my hallmarks, just kind of approaches with a clean slate, are that polycystic ovarian syndrome I call AAE, or anovulatory androgen excess. Okay, and so it's essentially a group of symptoms that are related to anovulatory menstrual cycles or menstrual cycle dysfunction, you could say, plus a group of symptoms related to high levels of androgens. Now, this is not perfect, and I think that this is another piece that is so important to understanding how to actually personally, practically approach an individual, because all androgens are not the same. How we test for androgens is not the same. How somebody's levels of androgens are going to fluctuate over the course of a day, a month. There are different types of androgens in our body, and having high levels of some of them might equate to one thing and kind of transpire and cause one dysfunction, whereas another set of androgens being high might cause and relate to another thing. So it's not unified, it's not uniformed, it's not, it's really not that simple to actually diagnose somebody with it. Similarly, anovulatory cycles, I mean, that is something that is, it's so unique to each situation and each individual. And that there are other things that got thrown into the mix with anovulatory cycles and high levels of androgens, that then kind of the internet has swooped up and then call that PCOS as well. So I don't know if that's made any sense. I don't know if that's
the internet saving things as
oh
usual.
God. Oh,
always making things so much better, especially in this world. But no, I think
mud.
Yeah. I think it makes it pretty clear. So, issues with ovulation, and that could be a whole host of things, right? And that could include cysts. It might not include cysts. And then the high androgens, which could be presenting in a bunch of different ways. Those two things together is what you're deeming.
Correct.
It used to be called PCOS. Now,
yes, correct. So one of the questions that typically people have associated with PCOS is, do you have irregular periods?
Mm-hmm.
And androgen excess?
Mm-hmm.
And I say, yes, that means that you have still potentially, because there's other things going on here, this polycystic ovarian syndrome. if you do not have high androgens, but you have an irregular period, I will go to my grave fighting this one. You don't have PCOS. You have something that needs to be properly clinically gone through to be able to determine why you have an irregular menstrual cycle or an anovulatory cycle. And if you have polycystic ovaries and you don't have high levels of androgens, that's something that needs a full clinical workup. They can't just stop at an ultrasound and call it a day and give you some drugs and move on. Like, that is so hazardous. Likewise, if you have high levels of androgens, but in all accounts, you are healthy. And by that, I mean you have a regular ovulatory menstrual cycle. You are not at risk for things like high cholesterol or hyperlipidemia or fatty liver, insulin resistance. Like, if you have these high levels of androgens that are relatively benign, and that's just you, and it's always been that way, I would argue that's not something that needs to be treated. Because we have this massive spectrum of human difference. And if anybody follows some of the rules in elite sport over the last couple of years, it was they called it the testosterone ruling, which meant that female athletes that had high levels of androgens that were deemed to be too high got told to chemically reduce them. Even if those androgens were, like I said, benign. That was them. And as female athletes with higher levels of muscle mass, typically speaking, there's higher levels of androgens associated with that.
Yeah, you can't tell me that most of the Olympic athletes aren't higher on that spectrum, right? Like, it just doesn't make sense. Like, why?
They're there for a reason.
They're there for a reason.
Yeah.
And there's going to be certain things that are skewed, different ways.
Yeah, absolutely.
And, obviously too much of something can be a negative.
Absolutely.
But not always, like you're saying in this case. So
not
what are some
always.
of those symptoms that you would like? So say PCOS, AAE, what are going to be some of those symptoms? Say you do, you do fall into these categories. Like, what are some of the things people could be looking for?
Yeah. So the kind of the phenotypes, they're going to vary, but I'm going to go off of what I'm going to call a classical AAE. But again, I want people to understand that there's outliers. There's always going to be outliers. And that is so important to understand why somebody has, and we're just going to take apart androgens. Why do they have high androgens? What is actually elevated and how did it get elevated? And is this an acute occurrence, meaning that it's as a result of, say, taking a certain drug? Or is it chronic and it's actually been an issue that's been ongoing? And by acute, I mean just like a low amount of time, of that drug that has caused this acute rise in androgens that, say, after you come off this corticosteroid for, let's say, IBS, then all of a sudden your androgens drop. So the kind of the categories and things that I look at are co-occurrences of what happens in individuals. Then this is backed by, since the 1930s research on women that have anovulatory cycles or menstrual disturbances, high levels of androgens, and their relationship between insulin resistance / metabolic derailment. Because high levels of androgens in some bodies can cause certain impacts for metabolic function, such as insulin resistance, obesity, alterations in, from carbohydrate distributions to dyslipidemia to vascular dysfunction, cardiovascular disease, sleep apnea, thyroid dysfunction, things such as secondary hair growth from the high androgens, things such as voices that drop, clitoral growth, the things that people typically associate actually with anabolic androgenic steroid use in women, but it's a natural occurrence. With that being said, and this is again why it goes back to why this can get so confusing, is that you can have, in some professionals' opinions, drug-induced high levels of androgens and anovulation. You can have it from immune and inflammatory responses. You can have it from adrenal androgens, not just ovarian androgens. You can have it from adipose, because adipose itself is an endocrine organ. We are, in some individuals more than others, it has a profound impact on androgens and how we actually utilize them, and also insulin and blood glucose function overall. There can also be impact for things like, even just genetics. Unfortunately, there's a huge genetic component that we're now starting to understand, and that the family studies on this have been so compelling. And by that I mean is that they've done large groups of data and of samples looking at twins and also siblings, and looking at the occurrences of not only certain types of reproductive dysfunction and high levels of androgens, but then looking at what genes are we seeing that are similar. And there is now this massive list of genes that are associated with the hyperandrogenism and ovulation. But here's the deal. It's not one uniform gene, and it's not genes that only work at one process in the body. There are genes that are connected to things like gonadotropins and how we actually stimulate our reproductive axes from our hypothalamus, from our pituitary. So FSH and LH genes. They've looked at it and they found ovarian genes and genes within our ovaries that alter how we not only receive signals, but how we metabolize and convert certain hormones. Also insulin resistance genes related to inflammation. So there's not, and that again, that kind of should help to illustrate that it's not one uniform thing. That even when we look at the genetic root, there are many different genes. Some individuals they found have only a couple. Some individuals they found have multiple different kind of derailments of sorts along the way. And that it's very common, for example, and I, again, speaking from personal experience with high androgens and ovulatory periods, I've got two older sisters. They both have been diagnosed, and quite young, one quite young, one postpartum, with polycystic ovarian syndrome. I actually have a bunch of female cousins that have also been diagnosed with it on my paternal side. And then some of the other influences include maternal stress, believe it or not, that they've now linked that the higher the stress that a mother has had during pregnancy, so the higher adrenal drive, the higher adrenal androgens that get produced, the more likely the offspring is going to have alterations in how they are not only able to manage stress on a chemical physiological level, but also how they're able to create, respond, and make DHEA, which is stress androgen that's made in the adrenals.
So is that why you see some people will say like there's different types of PCOS? Like there's an adrenal PCOS, there's an inflammation PCOS, there's a insulin resistant PCOS. Like are those proper terms, or is that like if somebody sees that, is that's kind of like, oh, that's not good information, or that's
So I'll be honest, I'm mixed.
Okay.
And I'm mixed because there are so many different variables involved with each of those that I still think we have to go one step further before we throw somebody into the diagnosis clinical gauntlet of treatment. Because I think that when we look at somebody that say has been associated with adrenal PCOS, so adrenal PCOS, and maybe it would help for me to walk through some of the different, like, the flow chart of sorts of what actually happens with the body.
Go for
it. That's might be the easiest. So why does somebody have high levels of androgens and some type of reproductive derailment that has resulted in an anovulatory cycle, which means that you can still have a bleed and have an anovulatory cycle, and you should go and watch Laurin and my podcast we did a couple months ago. How's that for plugging? And I'm not even a YouTuber.
Wow, that was really good. I'm so proud of you.
Thank you.
Yeah, it is actually it's on this podcast feed. I don't remember the number, but it is on here, and it's also on my YouTube channel. So we did 2 of those. So wow, good. Look at you, double dipping on the content.
Yeah.
Killing it.
Just because then I also don't have to go back into that thing.
There's like 2 hours of content there you can listen.
Exactly. So whenever we talk about genes, it's important to remember that genes aren't destiny. We have to put genes and environment, they work together. And so if we think about kind of this how this thing happens, it's typically speaking genetics and environment or lifestyle. And those two things come together to create some type of homeostatic shift in the body, some type of biochemical change that results in high levels of androgens that could be from many different origins. And I'll get into that in a second, but let's just say for right now, just high levels of androgens, that then a response of that is insulin resistance or a decrease in insulin sensitivity. And as a result, we're also seeing patterns that affect adiposity and our adipose. And from the actual androgens, we're seeing things like hyperandrogenism, anovulatory cycles, hyperinsulinemia, polycystic ovaries, metabolic syndrome. But we can also see insulin causing hyperinsulinemia. We can also see adiposity causing metabolic syndrome. Insulin is also related to both that and polycystic ovaries. So it kind of starts to now get braided. And from each of those, we see kind of what I call the end result, AKA acne. Acne is an end result. It's not the beginning. It's happened because a whole bunch of things have happened before it. Hirsutism, irregular menstrual cycles, subfertility or infertility, insulin resistance, diabetes, cardiovascular diseases, non-fatty alcoholic liver disease, all these things that have become associated with this kind of very complicated neuroendocrine derailment plus metabolic dysfunction. And so when it is, when people have associated it with like the insulin resistance or insulin related PCOS, that's typically thought of as that insulin is the driver. So the way that I see this is that you've got these different drivers of dysfunction. So something has caused one thing. It's almost like the domino that hit first that caused a whole bunch of other things. Now, not everybody agrees with insulin being the driver. Some people think that it's only androgens are the driver and insulin's not, and that somebody can have funky insulin and high androgens, and unless there's something else going on, then that's never going to be an issue. But that's not uniform. Like I said, these are not uniform. This is merely just, for simplicity's sake, I'm taking a stance to help people maybe kind of understand it a little bit more, but we'll come back and probably end up picking some of the stuff apart. And so when people have perceived kind of this like driver being insulin, it's that something has caused in an individual hyperinsulinemia. And hyperinsulinemia then causes some alterations in liver function, particularly IGF-1 changes, as well as something called SHBG or sex hormone binding globulin. It's also changed free fatty acids and how we respond to them. It's changed how we respond to changes even at the skeletal muscle itself and how the muscle manages and handles both insulin and blood glucose. It also influences how our pituitary signals our gonadotropin hormones, so FSH and LH. And then as a result, because of all these this landscape, it has created hyperandrogenism. And that the hyperandrogenism feeds into this loop, which then goes back up into the insulin resistance or hyperinsulinemia, and it just then keeps going around and around and around and around and around. And now that's that. Other things that they've kind of associated with that insulin resistance too is central abdominal fat, being somebody who's going to be higher at risk for it, somebody who has a family history of type 2 diabetes, somebody that has other types of genetic mutations of sorts that have kind of put them more at risk for how they handle blood glucose and insulin at various sites within the body, even pancreatic function, aging, unfortunately, certain types of drugs, and lifestyle. So they're pretty, I mean, those are pretty broad stroke things to kind of say, like, this puts you at risk for it. But again, for simplicity's sake, now that's
breathing.
Only one type. Yeah. Or not breathing, actually. Yeah. Not sleeping puts people at risk for it. But a second type that gets associated or kind of phenotype would be immune or inflammatory related PCOS. And that's that something has caused chronic inflammation, and chronic inflammation is the driver. Now, I would argue with that, though, that chronic inflammation gets caused from things like lifestyle and genes and insulin resistance. So Now, could somebody have chronic inflammation without having those things? Sure. Does chronic inflammation automatically equate to, this neuroendocrine derailment that we call PCOS? Not always, and not in everybody, because it's always going to be the sum of all factors. But that chronic inflammation does cause their own kind of factors of derailment. And that I believe, and I've seen this both within the research and within my practical work, that inflammation is a huge piece of how we actually help somebody who has polycystic ovarian syndrome or hyperandrogenism plus anovulatory cycles. And that chronic inflammation is such a massive, massive beast, but it is often overlooked as being a driver of dysfunction. And that's something that does have a profound impact on how somebody is able to actually navigate and manage high androgens and ovulatory cycles.
What would be a good way for people to know if they have that? Like, I would say low-hanging fruit is if you're getting blood work, CRP levels are going to be really beneficial.
Yeah, CRP, homocysteine, certain levels of things even B12, B9, vitamin D. Vitamin D is vital for how our body's able to actually respond and manage to inflammation. And that, keep in mind that those test results, especially for CPR, it's kind of fluid. So training is going to impact something like that.
Yeah.
The other
training
thing
impacts so much blood work and people don't realize that.
Yeah. The other thing too, when it comes to inflammation, is you can just ask yourself about your lifestyle. Are you somebody that's eating like an asshole? Because we know that the Western diet is absolutely huge for increasing how the body is able to handle and respond to inflammation. Similarly, are you somebody that has some really acute changes following training or some type of stressful event? Are you somebody that has autoimmune issues in your family, hereditary based? That's something that's also immune inflammation. Often things like even markers or for pre-lupus are a signal that somebody has high levels of inflammation. So definitely there are lab work, but it's also just, I am a proponent that if you work upon and try to improve somebody's inflammation, it's not like giving them a fistful of anti-androgens. It's a little less benign, and it's going to have far-reaching repercussions that are positive and don't come with a hell of a lot of negative impacts. Adrenal-related PCOS, another subtype. So this is typically seen to be from related to how the body is handling and managing stress, either acute or chronic, as a result of adrenal load. So androgens get made from our adrenals. As I mentioned, they get made also in our ovaries, and they also get made in adipose, as well as other things. Here's the big other things. I'm only talking about endocrine creation of hormones. There's intracrine, paracrine, autocrine. Endocrine is just, it's one small term and really does not properly depict how our body makes, transports, binds hormones properly. It's very archaic, actually, when it comes to the body and our understanding about the body. So with the adrenals, the idea is that adrenals create more DHEAS, which then also causes an increase in androstenedione, which is a secondary. And then that causes peripheral conversion of testosterone. Testosterone then alters our kind of how our muscle alters the glucose uptake, alters things like your insulin resistance as a result of that. And then insulin resistance over time causes elevated insulin levels, which then impacts our ovaries, which then also impacts our pancreas and our liver and our abdominal fat, and start feeding into this feedback loop, because now you also have your ovaries that are getting affected by your adrenal. It's a bit of a narrow perspective. I'm not 100%. I think that it's narrow in the fact that we have our hypothalamus pituitary adrenal axes, and we also have our hypothalamus pituitary ovarian axes. So the adrenals are one piece, but we have to go one step further, and that's the pituitary. So I would argue that adrenal related is actually pituitary and hypothalamus related, because you can't dissect it's very rare that I see people that have high levels of DHEA that don't also have ovarian markers of dysfunction. It's very rare that I see people that have some type of adrenal related issue and they don't also have anovulatory cycles, even if they don't have high levels of DHEA. So I do think that that's something we have to be mindful of and careful of. Drug induced is another category. So either, and this one just blows my fucking mind. Women who get diagnosed with anovulatory cycles when they're on hormonal birth control.
Isn't that the whole point?
Yeah.
Hey, congrats, your birth control is working. Like,
yeah.
We should be more concerned if this actually wasn't the diagnosis.
Yeah. So how one drug can be used to both cause and treat PCOS blows my mind. Because I'm like, that just doesn't, like, So hormonal contraceptives, some types can cause signs of high levels of androgens, even if your lab work does not show high levels of androgens because of how the actual progesterone that's in it, which you can go to the other podcast we did, and we talked about this.
There we go.
The birth control one.
Double plug.
Yeah, because there are different forms of birth control, hormonal birth control, that have different types of progesterones. Those that are derived from androgens typically are associated with higher androgenicity, which would just simply be symptoms that we associate with high levels of androgens, even when androgen levels aren't actually high in the body, because you're shutting down your ovarian testosterone production when you're on the pill. That's what the point is. But that doesn't mean that your adrenals aren't affected, even though typically speaking, DHEA does get dropped down. So it's that peripheral conversion that the progesterones like to rear their ugly head in and cause things like facial hair growth in women or hair changes. So there's this derailment of sorts that hormonal contraceptives can cause, but they can also cause that when women go off of them. So that's where this whole notion of post-pill PCOS comes in, which literally makes me want to go out in the middle of the street, scream, start like kicking the concrete, and then run away and never come back from society.
So tell us how you really feel about that. So that's so if you see that diagnosis, that's not a good, it's what I'm gathering from you.
Yeah. So remember what I said about acute changes that happen with drugs?
Yeah.
So when a woman comes off the pill, it takes the body a while to figure out what the heck to do. And if a woman is on a pill that had an androgen blocking or anti-androgen effect, often what happens is almost like an androgen rebound, and it's not long-term a lot of the time. Often it will happen right away and then it will drop. And so individuals will treat it when it's high, and they cause so much damage. There's some things that women, exactly, there's some things that women can do in advance of coming off the pill to actually help with that. If you have things like your inflammatory response managed, if you have things like your thyroid managed, if you have things like just giving your body the micronutrients it needs to handle this new hormonal process that you put your body in, typically speaking, you're not going to get that high. Now, if somebody is prone to something like androgenic acne, they might, but it doesn't mean you have high androgens from all sources in your body into nuclear androgens. It means that your androgens are binding in your skin, and that's what needs to be addressed. So I just caution people who, within that first 6 months, say, I have PCOS of coming off the pill, because no, your body's regulating. Now, after 6 months, and I would say for some people, if they've been on it 17 years, or if they've been on it because they initially had a diagnosis of PCOS, then yeah, it's going to take time and it's going to take effort to get you in a better hormonal state. But post-pill PCOS, I mean, it's like saying you have PCOS when you have been on anabolic androgenic steroids. That's the whole fucking point.
Yeah.
So if we look at the two things I said, high hyperandrogenism and anovulatory periods. Birth control is supposed to cause anovulatory periods. Anabolic androgenic steroids are supposed to cause high levels of androgens. These two things, though, are not mutually exclusive, and they can happen with other instances as well. Somebody can have anovulatory periods, like I said, and not have high levels of androgens, which post-pill users need to be mindful of.
Mm-hmm.
Also, high levels of drug-based from androgens can cause high levels of androgens while you still have low levels of ovarian testosterone because you shut down your axes. So again, I'm sorry if I'm confusing people, but this is the type of stuff I deal with every single day. Diagnoses, Lauren, to be honest, they make us feel safe and comfortable. They give us
100%.
They give us a security blanket to make us feel okay when we try to control our body and our body is not listening to what we want it to do. Whether that is we've gained weight and we can't understand why. And so all of a sudden we go to the doctors and we get this diagnosis that literally is like this blanket around us. And it goes like, I know what it is now, so I know what to do. But the reality is that none of us have the power to control the human body. The human body is so misunderstood. We know so little about it. And that even things that we think we know about, we still have no fucking clue. When it comes to women, we don't even understand where women bind most of their androgens in their body. Like, we don't know where most of the androgen receptors are in the female body. So how are we supposed to understand hyperandrogenism?
And what you made such a great point right there is like, people want a diagnosis. And this is so common with any hormonal issue, any weight gain issue, any acne issue, like all of these things go together, right? And it can be really frustrating for people who have, have had jacked up dieting histories, who have had all of these side effects, these symptoms for a really long time. And I mean, everybody falls into this, like myself included. Like, we all just want an answer, like, hey, I've been feeling like XYZ, just tell me what it is. And what ends up happening, unfortunately, is that a lot of times people will get to like their wit's end of like how upset and how vulnerable they feel, and then they meet somebody who then tells them all of these answers, like, and so if anybody ever gives you a very, very certain diagnosis, right, or even diagnoses, like they might give you multiple, usually that person is full of shit. And I say that with full confidence, because if you guys have been listening to this entire podcast, you'll notice that while Victoria is incredibly intelligent and probably one of the only people that I trust in this area, it's hard to get a very direct answer, right? And that's actually what frustrates a lot of people who don't understand how theory and research works, is because they want a direct answer. They want to either have an answer for themselves, or they want to give their clients an answer because they want to feel like they have, all of the power, all of the resources, and understandably, like, you want to help people. If somebody's struggling, you want to be like, hey, I know what you have. But it's not that easy, whether it's hormonal, whether it's metabolic, whether it's digestive. None of these things are straightforward. So it requires a lot of teasing out, and it requires a lot of test this and let's try this, and test that now and let's see where these things are at, and changing small variables over time to really, really work on things. So I know it can be frustrating, especially if people listen to this and they were hoping like we were going to just divulge all of the PCOS like secrets in the whole world. And I can say with full confidence that Victoria is one of the most qualified people to talk about this. And clearly there are still tons of questions that remain unanswered. So it's going to require, a lot of concerted effort, a lot of testing, a lot of slow, deliberate changes. And that's just the way that it is. And it might be PCOS, but it might not be. So it's really understanding to be open to like, hey, I don't know what's going on, and let me really track all these symptoms instead of just slapping a label on and saying, okay, I know what I have.
Yeah. And other things that can cause that co-occurrence are thyroid issues, whether untreated or treated, because the thyroid treatment changes how we bind androgens. That's what T3 does. Vitamin D deficiency, like nobody goes and says like, oh, I have anovulation and high androgens because I'm D deficient. But the reality is that is a potential underlying issue. Or zinc deficiency, or under eating or overeating. People automatically associate under eating with hypothalamic what is that? Functional hypothalamic amenorrhea.
Mm-hmm.
But it's like some individuals do get high levels of androgens because their adrenal output is so freaking high. And not everybody does. And so that's where it's really, like you said, it's so dangerous to just take something and run with it. And there's a lot of individuals, like there's a lot of really cool practitioners out there that are doing some great work. But if they say, hey, there's only 4 types of PCOS, and if you have insulin resistant, it means you have insulin resistance PCOS. And if you have normal periods before the pill, it means you've got post-pill PCOS or any of that stuff. I caution it. I suggest you question and you really critically think about it, because co-occurrences is how the body works. Nothing happens in isolation. Nothing does. I mean, a great example is that antidepressants can cause hyperandrogenism and anovulatory periods. And people think that they're taking an antidepressant simply for their brain chemistry and their neurotransmitters. But at the end of the day, it's called the neuroendocrine system, because our neurotransmitters and our like reproductive hormones and other hormones, other steroid molecules and non-steroid molecules that act on and influence our reproductive axes and other endocrine axes in the bodies are influence our neurotransmitters.
Same way the hormones can influence the opposite way, right? Like,
yeah, absolutely.
So why wouldn't it be, it can go both ways, either with, like you said, neuroendocrine. They go together.
Yeah.
And there's so many coexisting factors that people have to consider.
Yeah. And that ultimately it's hard to tease it. Like, I am a researcher that literally I've spent the last now over a decade. I've been in post-secondary for longer than I was in non-post-secondary education. It's disgusting, actually. I've spent 3 years of my life not in school. And I'm in my 30s. Like, it's a lot. And it's way more than anybody should ever, to be honest. But I have to say, like, I love the hunt of knowledge. I love going down the rabbit hole as a critical interdisciplinary researcher and finding an answer. But when it comes to the human body, you are never going to have a single answer. We're never going to be able to say, do periods impact performance? Or does birth control cause changes in body composition? We will never, because all of us are different. All of us are. And if the genetic kind of universe has taught us anything, it's that even when it's a single phenotype like insulin resistance, there is so many different genes underlying it. And then you have to put those genes in this massive genetic soup and with all these other genes and how they interact with each other. And then you put those inside the body itself, and then you put the body inside an environment, and then you light it on fire with context. And whether or not those things are going to come forth is dependent on the individual. Like, it's so difficult. So I think to give people something, because this is what Laurin has taught me over the last couple of years, is to try to do summaries.
Yes. To wrap it up.
Is to do what I call pick your DD. So you could say driver of dysfunction, or I'm trying not to use the word dysfunction as much anymore because I just don't like it. So I've decided derailment is my new term I'm using. Okay. It all goes back to my doctoral research and getting picked apart by a critic. So derailment it is right now. That might change 6 months from now, but I'll let you guys in on that. So essentially, if somebody has anovulatory cycles and they have hyperandrogenism or high levels of androgens, pick a driver of dysfunction. 1, look at anovulation. Why are you having anovulatory or irregular menstrual cycles? And if you don't know if you're ovulating or not, that's step 1 before you go on drugs or start a different course of therapeutic pursuit. Go through high androgens and figure out what androgens are high. Are they high over time, or is it just because you got your labs done at a certain time of the month when your androgens are high? Is it because you're post-comp? Is it because you just went off the pill? So take time like a good researcher and gather your data. If it's insulin resistance, go through, figure out why or what could be some of the reasons for it. And because there are many, 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 many variables that can impair ovulation, promote excess androgens, and also to alter how our body handles and manages blood glucose and insulin, I do think it is important to focus on a single symptom or dysfunction, whatever you want to do, work backwards, find some potential root causes, because there's probably going to be more than one, and then treat or work through treatment as an individual on the whole, not just on the disease or phenotype that you think you have, because that's what's going to get you into trouble, and it's not sustainable for most of us. I mean, the great example is when it comes to, say, hyperandrogenism, that there are some pretty gross is a good clinical word to use, anti-androgens that get used that cause so many secondary issues, or what would be called unintended results, and that they're not meant to be done long term. And that realistically, if you go through and find out what are the high androgens influenced by, what are they influencing, and you actually build a proper clinical picture, that you don't need to go and use the extreme drugs. You can start with some basic interventions, let them take their course. If they aren't improving, say, your hair growth, then let's try some other interventions and some other interventions before you go to like Z.
That was a good summary. I'm proud of you. I'm glad you did that. I know that people need this. You're learning things. Look, you looped in 2 podcasts and you did a summary. I am so proud of you.
Do you know what I actually have written down? Like, I have, what would Laurin say when it comes to anything with my business? And whenever I have any business decisions now, I'm like, what would Laurin say? And then I'm always like, Laurin handles life like a boss, and I need to start doing that.
Very small things that I can do. But hey, I don't know this stuff. You do. I can help you with business stuff. And it's perfect. But speaking of Victoria helping, not only myself, I've done consulting with you for many years now, and just such a wealth of knowledge. Victoria does offer consulting. So if you guys are interested in that, she has a newly revamped site. So proud. And if you want to reach out to her for more information on this, you can. What is the site so we can direct people there?
It's just my name. So it's just victoriafelkar.com. It's nice and simple.
Perfect. So if you spell her name right, you will find it. It's the first thing you can search. And then, yeah, you guys can reach out for consulting. And I would say that it's an amazing thing. I send clients to her in conjunction with nutrition coaching. Everybody needs a reference in certain areas, right? So for example, whether it's mental health, having a therapy reference or having a gut health specialist. And, Victoria is what I would consider the team's like hormone specialist, who I would recommend people to go see, because like I talked about, it's very, very hard to find credible people in this area. And a lot of people are taking advantage of things when they shouldn't. So thank you guys so much for tuning in. We will do part 2 on some of the questions that I got. I got some really awesome questions on my Instagram, so I kind of compiled the best ones and the best topics. And so stay tuned for that. It'll be out on Wednesday. Thank you so much for coming on, and catch you guys next time.